What if I told you that the very medications you take every day, thinking you are staying healthy, might actually be slowly stealing your vitality? This is not some fringe theory. It is the conclusion drawn by scientists and geriatric specialists who have been sounding the alarm about certain drugs that cause devastating, yet preventable, effects in adults over the age of 65. We are talking about adverse drug reactions that send over 2 million older adults to emergency rooms every single year. That number, 2 million, is shocking, and the truly alarming part is that most of these emergencies were completely preventable. The problem is systemic. Most doctors simply do not have the time to walk you through what a landmark study from Johns Hopkins revealed, or explain every single risk of every medication. You may not get the explanation for why your parent suddenly became confused, or why your spouse keeps falling. These drugs have been hiding in plain sight, sitting innocently in medicine cabinets across the country, taken every morning without a full understanding of the risks. Today, I am exposing the top 5 medication classes that, based on decades of geriatric research, I would never let my loved one take if a safer alternative existed. We will not just identify the threat. We will walk through the precise, science-backed protocols for getting off these drugs safely and effectively. We will start with the silent thief, then move through the brain-fogging pills, the bone-breaking stomach drugs, the bladder drug brain threat, and the pain paradox. By the end of this 30 minutes, you will have the knowledge to advocate thoughtfully for the health of those we love. We begin with the medication millions of seniors reach for every single night, believing it is a harmless sleep or allergy remedy: the anticholinergic deception. At number 5 on our list are medications containing diphenhydramine, the active ingredient in Benadryl, and countless over-the-counter sleep aids like Tylenol PM, ZzzQuil, and Advil PM. This easy availability makes people assume it must be safe. However, that assumption could be harming your loved one's brain. Diphenhydramine belongs to a class of drugs called anticholinergics. These medications work by blocking a vital chemical messenger in the brain called acetylcholine. Acetylcholine plays a crucial role in memory, learning, and attention. When you block it, significant cognitive problems can develop. The evidence against this common chemical is terrifying. A groundbreaking study published in JAMA Internal Medicine in 2015 followed nearly 3,500 adults aged 65 and older for over 7 years. The researchers discovered something alarming. People who used anticholinergic drugs like diphenhydramine for 3 years or longer had a 54% increased risk of developing dementia. Let that number sink in. Taking Benadryl regularly for 3 years increased dementia risk by more than half. The problem is compounded by a basic biological reality of aging. As we get older, our livers and kidneys become less efficient at clearing medications. This means diphenhydramine stays in an older person's system much longer than in a younger person. A dose that might wear off in 4 hours for a 30-year-old might linger for 12 hours or more in someone over 65, continuing to block acetylcholine in the brain. The effects are cumulative. Each dose adds to the burden. An older adult's brain is already more vulnerable because acetylcholine levels naturally decline with age. Many seniors do not even realize they are taking this drug because it hides under dozens of brand names and lurks in combination products marketed for colds, allergies, and sleep. Your loved one might be taking the same anticholinergic chemical multiple times daily without knowing. The solution for the anticholinergic deception is surprisingly simple. For allergies, newer, safer antihistamines that do not cross into the brain work much better for older adults. Cetirizine, Zyrtec, and loratadine, Claritin, provide effective allergy relief without the cognitive risks. For sleep problems, the answer requires a completely different approach entirely. Cognitive behavioral therapy for insomnia has been proven more effective than any sleep medication in the long term. A 2016 study from the American College of Physicians found that cognitive behavioral therapy produced better sleep outcomes than medications and had zero side effects. Low-dose melatonin, typically around 0.5 milligrams to 1 milligram, taken 2 hours before bed, can also help regulate sleep cycles naturally. The key is addressing why sleep is disrupted, rather than sedating the brain into submission. Talk to a doctor about tapering off diphenhydramine slowly and implementing these safer alternatives instead. Next, we move to number 4 on our list, a class of drugs that seems innocuous but is actively compromising both cognitive function and physical safety: the dementia and fall connection. We are talking about benzodiazepines, medications that doctors have been prescribing for anxiety and sleep for over 50 years. These include household names like Xanax, Valium, Ativan, and Klonopin. These drugs produce rapid relaxation and sedation by enhancing the effect of a calming neurotransmitter called GABA in the brain. However, they are creating significant and often unrecognized harm among older adults. The American Geriatric Society explicitly lists benzodiazepines on its Beers criteria, which is a list of medications that should generally be avoided in people over 65. This is not a controversial stance. The evidence against these drugs in older adults is substantial. A landmark study published in the British Medical Journal followed nearly 9,000 adults over 65 for 15 years. The findings were definitive. Those who used benzodiazepines had a 51% higher risk of developing dementia. Importantly, the researchers controlled for other factors, such as depression and anxiety, that might otherwise explain the connection, suggesting that the drug itself appeared to contribute to the cognitive decline. Beyond the direct neurological impact, falls represent another devastating consequence of benzodiazepine use in older adults. These medications cause sedation, impaired coordination, and slowed reaction times. A systematic review published in Age and Aging found that benzodiazepine users were 41% more likely to experience falls. A fall for an older adult can change everything. It can mean a broken hip, loss of independence, nursing home placement, or even death. Every year, 3 million older adults are treated in emergency rooms for fall injuries, and benzodiazepines contribute to many thousands of these preventable accidents. The dependence potential of these drugs creates additional insidious problems. Benzodiazepines were designed for short-term use, typically only 2 to 4 weeks. Yet, many older adults have been taking them for years, even decades. Physical dependence develops quickly. Stopping abruptly can trigger dangerous withdrawal symptoms, including seizures. The brain becomes accustomed to the artificial GABA enhancement and loses its ability to calm itself naturally without the drug. This creates a tragic situation where the medication originally prescribed to reduce anxiety now causes severe anxiety whenever someone tries to stop taking it. The dependence effectively traps the patient in a cycle of risk. Breaking free from benzodiazepines requires a careful, gradual approach. Let me be clear. Stopping suddenly is dangerous and unnecessary. Instead, you must work with a knowledgeable doctor to implement a slow, medically supervised taper. A safe protocol involves reducing the dose by about 10% every 1 to 2 weeks. This slow taper allows the brain to readjust gradually. During the tapering process, implementing other anxiety management strategies helps fill the gap. Cognitive behavioral therapy has strong evidence for treating anxiety without medications. Regular exercise produces natural calming effects by boosting endorphins and reducing stress hormones. Mindfulness meditation practices have been shown to physically change brain structures involved in anxiety regulation. Some older adults benefit from switching to a longer-acting benzodiazepine during the taper, which produces more stable blood levels and easier dose reduction. The ultimate goal is complete discontinuation, but reaching that goal safely takes time and proper medical support. Moving on to number 3, we encounter medications that seem completely harmless, yet their long-term use in older adults carries devastating risks to the skeleton and the immune system. The bone and gut sabotage. I'm talking about proton pump inhibitors, or PPIs, commonly known by brand names like Prilosec, Nexium, and Prevacid. These are prescribed for heartburn, acid reflux, and stomach ulcers, and they are incredibly effective at their intended job, reducing stomach acid dramatically. It is that very effectiveness, however, that creates serious problems when these drugs are used long-term by older adults. Stomach acid exists for crucial reasons beyond just breaking down food. It helps break down food so nutrients can be absorbed. It kills harmful bacteria before they can infect you. It activates enzymes needed for proper digestion. Critically, calcium requires stomach acid for proper absorption. When you suppress stomach acid for months or years, the consequences ripple throughout the entire body. The most well-documented danger is to bone health. A study in the Journal of the American Geriatric Society found that PPIs increase the risk of hip fractures by 35% in older adults. This fracture connection makes perfect sense when you understand the science. When you block acid production, calcium cannot be absorbed efficiently. Over time, bones weaken. For an older adult who already faces increased fracture risk, this medication-induced calcium malabsorption can be devastating. A single hip fracture in someone over 65 leads to death within 1 year in 20% to 30% of cases. These are not abstract statistics. These are real people whose bones broke because their heartburn medication was interfering with calcium absorption. Furthermore, a 2016 study published in JAMA Neurology that examined over 73,000 adults aged 75 and older found that regular PPI users had a 44% higher risk of dementia compared to those who did not use these drugs. The second major area of concern is infection risk. Remember how stomach acid kills bacteria? Without that natural protection, dangerous bacteria like Clostridioides difficile can survive passage through the stomach and colonize the intestines. C. diff infections cause severe diarrhea, dehydration, and can be fatal in older adults. A meta-analysis combining data from multiple studies found that PPI use increased C. diff infection risk by 65%. The path forward involves understanding why acid reflux happens in the first place. For most people, lifestyle modifications can dramatically reduce symptoms and allow for safe discontinuation of PPIs with a doctor's guidance. Here are the actionable steps for managing reflux naturally. Eating smaller meals reduces pressure on the stomach valve. Avoiding food within 3 hours of bedtime prevents acid from pooling while lying down. Elevating the head of the bed by 6 inches uses gravity to keep acid where it belongs. Losing excess weight removes pressure from the abdomen. Identifying trigger foods, which commonly include coffee, chocolate, alcohol, and spicy dishes, allows for targeted avoidance rather than wholesale acid suppression. If medication is truly necessary, using PPIs at the lowest effective dose for the shortest possible time minimizes risk. Many people who have taken PPIs for years can gradually taper off under their doctor's supervision and manage symptoms through these natural approaches instead. The medication class that earns the number 2 spot on our list might surprise you, but it is one that I am most concerned about for long-term cognitive health: the bladder drug brain threat. We are specifically discussing the strongest anticholinergic drugs commonly prescribed to older adults, particularly bladder medications like oxybutynin, Detropan, tolterodine, Detrol, and solifenacin, Vesicare. These medications are routinely prescribed for overactive bladder, a condition that affects millions of seniors and profoundly affects quality of life, causing urgency, frequency, and sometimes incontinence. The danger is that they may be systematically harming brain function in ways that go unrecognized. We briefly discussed anticholinergics in the previous section with diphenhydramine. These bladder medications represent the most potent anticholinergics commonly prescribed, and they flood the body with the same acetylcholine blocking effects, but at a far greater strength. Acetylcholine, remember, is the critical brain chemical for memory and attention. The evidence is powerful and demands immediate attention. A 2019 study published in JAMA Internal Medicine examined medical records from over 280,000 adults aged 55 and older. The researchers found that strong anticholinergic drugs increase the risk of dementia by 50%. For each additional year of use, the risk climbed higher. Among the highest risk medications identified were these bladder drugs. The difficult reality is that seniors, desperate for relief from incontinence and urgency, take what their doctors prescribe, trusting they are appropriate. They have no idea that they may be trading bladder control for brain function. This is not a trade most people would accept if they were fully informed about the risks. The brain effects often go unnoticed at first. Confusion develops gradually, and memory lapses accumulate. Family members might simply attribute these changes to normal aging, and the medication connection remains hidden. A study in the Journal of Clinical Pharmacology found that older adults taking oxybutynin showed measurable cognitive decline within just 2 weeks of starting the medication. Imagine the cumulative impact from years of continuous use. Thankfully, better options exist for managing overactive bladder, and they should always come first. Behavioral approaches are the foundation of treatment. Bladder training involves gradually increasing the time between bathroom visits, which trains the bladder to hold more urine comfortably. Pelvic floor exercises, often called Kegels, strengthen the muscles that control urination. When performed consistently, these exercises have been shown to reduce incontinence episodes by 60% or more. Limiting fluid intake in the evening reduces nighttime urgency. Avoiding bladder irritants like caffeine, alcohol, and artificial sweeteners can make a significant difference. Timing medication doses, particularly diuretics, for earlier in the day prevents nighttime problems. If medication becomes necessary despite these behavioral approaches, newer options carry a much lower risk. Mirabegron, Myrbetriq, works through an entirely different mechanism that does not block acetylcholine. Studies show it is effective for overactive bladder without the cognitive side effects. Vibegron, Gemtesa, represents another excellent, non-anticholinergic option. For older adults currently taking strong anticholinergics like oxybutynin, discussing these alternatives with a healthcare provider could be the single most important action they take to protect their cognitive health. Finally, at number 1 on our list, we confront one of the most significant medication challenges in modern healthcare, a class of drugs that, while necessary for acute, severe pain, is catastrophic for long-term use in seniors. The pain paradox. I am talking about opioid pain medications, including drugs like oxycodone, OxyContin, Percocet, hydrocodone, Vicodin, Norco, morphine, and fentanyl. Although medical organizations have updated their guidelines significantly, millions of older adults remain on these medications, often without understanding the full scope of risks they face. The statistics are deeply concerning. Adults over 65 receive more opioid prescriptions than any other age group. A CDC study found that opioid-related hospitalizations among older adults increased by 34% in just 5 years. While overdose death is the most extreme outcome, the daily toll of opioid use in older adults is what truly alarms geriatric specialists. This toll includes severe constipation, so severe it requires emergency intervention, profound confusion, falls, and the phenomenon called opioid-induced hyperalgesia, which means the pain medication actually makes the chronic pain worse over time. The fall risk associated with opioids in older adults cannot be overstated. Opioids cause dizziness, sedation, and impaired balance in everyone. In an older adult whose coordination is already affected by aging, the effects are magnified dramatically. A study in JAMA Internal Medicine found that opioid use increased fall risk by 400% in the first 2 weeks of starting therapy. That 400% increase is a staggeringly high number and should serve as a flashing warning sign for anyone considering these drugs for long-term pain. The cognitive effects mirror those of the other drugs we have discussed. Research published in the Journal of the American Geriatric Society found that older adults taking opioids performed significantly worse on tests of memory and attention compared to those not taking these drugs. Long-term opioid use may contribute to lasting cognitive decline, and the brain changes that occur during chronic use do not simply reverse when the drugs are stopped. Finding better approaches to chronic pain is essential, and requires a fundamental shift in perspective. First, pain in older adults deserves thorough investigation rather than reflexive prescription. Sometimes, pain signals an underlying condition that can be specifically treated. Second, non-drug approaches to pain management often work better than opioids for chronic pain. We will dedicate the remaining sections to detailing these safer, non-pharmacological alternatives. For an older adult currently taking opioids, working with a pain specialist to develop a comprehensive tapering plan while implementing alternatives offers the best path forward. Physical therapy strengthens supporting muscles and improves function. Cognitive behavioral therapy for pain, CBTP, helps rewire how the brain processes pain signals. We know that CBT can reduce chronic pain intensity by 30% or more without any medications. Acupuncture has moderate evidence supporting its use for several chronic pain conditions. Topical treatments like lidocaine patches can address localized pain without systemic side effects. And finally, low-dose non-opioid medications like certain antidepressants, particularly duloxetine and specific tricyclics, can modulate pain pathways when other approaches are insufficient, providing relief without the risks of addiction, falls, or cognitive decline. The most common reason older adults begin taking dangerous anticholinergic medications like diphenhydramine is simple: they cannot sleep. So, let us immediately address this with a proven, evidence-based strategy that I call the Safer Sleep Protocol. The answer requires moving completely away from sedating the brain into submission and instead focusing on behavioral and natural regulation. The single most effective long-term treatment for insomnia is cognitive behavioral therapy for insomnia, or CBTI. A 2016 study from the American College of Physicians found that CBTI produced better sleep outcomes than any sleep medications and had zero side effects. CBTI is not just about relaxation. It is a structured program delivered by a therapist or through a self-guided app that addresses the thought patterns and behaviors that keep you awake. CBTI generally incorporates several key components. Sleep restriction. Sounds counterintuitive, but it involves intentionally limiting the amount of time spent in bed, initially to only the actual time spent sleeping. This increases your body's drive for sleep, making your time in bed more efficient. For example, if you are only sleeping 6 hours but spending 8 hours in bed, you restrict your time in bed to 6.5 hours for a week, and then gradually increase it as your sleep improves. Stimulus control involves strict rules to retrain your brain to associate the bed only with sleep. This means if you are awake for more than 20 minutes, you must get out of bed, move to another room, and engage in a quiet, non-stimulating activity until you feel drowsy again. Then return to bed. No reading, watching TV, or worrying in bed. The cognitive component addresses the anxiety and racing thoughts that often accompany insomnia, teaching techniques to challenge and replace negative thoughts about sleep. The goal is to re-establish the body's natural circadian rhythm. For many seniors, this rhythm is disrupted simply because they spend too much time in bed, taking naps during the day, or not having a consistent wake-up time. If a supplement is needed, the evidence strongly supports low-dose melatonin as a natural way to regulate sleep cycles. However, the dosage is critical. Many over-the-counter melatonin products contain way too much, often 5 milligrams or 10 milligrams, which can lead to grogginess. The effective, natural dose for regulating the body's clock is much lower, typically 0.0000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000000 5 milligrams to 1 milligram. This should be taken 2 hours before bed to signal to the brain that darkness is approaching and to begin the natural sleep process. It is not a sedative. It is a time-release signal. Another essential non-drug component is sleep hygiene. Optimize the bedroom environment for darkness, quiet, and a cool temperature, typically between 60 and 67 degrees Fahrenheit. Avoid caffeine and alcohol close to bedtime. Ensure bright light exposure in the morning to reinforce the wake cycle. By implementing the safer sleep protocol, starting with CBTI principles and using low-dose melatonin as a bridge, you can avoid the dangers of anticholinergics and benzodiazepines and achieve higher quality, sustainable rest. Always consult a doctor about tapering off diphenhydramine or other sleep aids slowly and implementing these safer alternatives instead. In the previous section, we identified benzodiazepines like Xanax and Ativan as profoundly risky for older adults, contributing significantly to dementia and falls. This is why implementing the safe exit strategy, the anxiety and deprescribing strategy, is crucial. Remember, physical dependence on these drugs develops quickly, and stopping abruptly is dangerous, risking withdrawal symptoms, including seizures. The key is the slow, medically supervised taper. The standard protocol involves a systematic dose reduction of about 10% every 1 to 2 weeks. This slow process allows the brain's GABA receptors to gradually resensitize and return to normal function. This is critical because the brain becomes accustomed to the artificial enhancement and needs time to readjust. For example, if your loved one is taking 1 milligram of Ativan daily, the first drop would be to 0.9 milligrams for 2 weeks. The next drop would be to 0.8 milligrams for 2 weeks, and so on. This process can take several months, but the patience is necessary for safety and success. During the taper, managing the underlying anxiety without medication is the focus. We must fill the gap created by removing the chemical crutch with proven behavioral tools. Cognitive behavioral therapy, CBT, for anxiety. This is the gold standard, non-drug treatment. CBT teaches patients to identify, challenge, and modify the unhelpful thought patterns that fuel anxiety. It is highly effective in helping the brain relearn how to cope. Mindfulness and meditation. Studies have shown that mindfulness meditation practices have been shown to physically change brain structures involved in anxiety regulation, specifically increasing the density of gray matter in the areas responsible for self-regulation and attention. Even 5 to 10 minutes of focused breathing daily can make a profound difference. Regular exercise. This is perhaps the simplest and most powerful anti-anxiety tool. Regular physical activity, such as a 30-minute brisk walk daily, produces natural calming effects by boosting endorphins and reducing stress hormones. It acts as a natural anxiolytic. Switching to a longer-acting benzodiazepine. Physician decision. In some cases, a doctor may switch the patient from a short-acting drug like Xanax to a longer-acting one with a smoother metabolic profile. This makes the smaller dose reductions during the taper less jarring on the central nervous system, which can be an effective bridge to eventual discontinuation. You must understand that the anxiety spike experienced during a taper is often a symptom of withdrawal, not a return of the original illness, a phenomenon known as rebound anxiety. By understanding this, patients and families can push through the temporary discomfort, knowing they are working toward a goal of complete, sustainable freedom from dependence. Never attempt this process without the guidance of a knowledgeable physician or a tapering specialist. The goal is complete discontinuation, and with a careful plan, it is an achievable goal that will protect your loved one's long-term brain health. We conclude our deep dive into safe geriatric pharmacology by addressing the most significant risk, chronic pain, and how to treat it without the danger of opioids. The path forward is through the multimodal pain solution, a comprehensive strategy that moves beyond the simple, reflexive prescription of opioids. Finding better approaches to chronic pain is essential, not just because of the fall and addiction risks, but because of the phenomenon of opioid-induced hyperalgesia, where the medicine actually begins to make the pain worse. This multimodal solution integrates 3 critical components: physical therapy, cognitive therapy, and non-opioid medication/topical treatments. The physical component, targeted movement. The foundation of pain management is often movement. Physical therapy, PT, strengthens supporting muscles and improves function, which addresses the root cause of many age-related aches, rather than just masking the symptoms. A good physical therapist will create a program that is safe and tailored to the senior's mobility level, focusing on joint stability and core strength. The cognitive component, rewiring the brain. This is the most underutilized and powerful tool. Cognitive behavioral therapy for pain, CBTP, helps rewire how the brain processes pain signals. Chronic pain is often less about ongoing tissue damage and more about the brain's hypersensitivity to signals. CBTP teaches relaxation techniques, activity pacing, and how to challenge catastrophic pain thoughts, essentially turning down the volume control in the brain. Studies show that CBT can reduce chronic pain intensity by 30% or more without any medications. The pharmacological component, non-opioid modulators. When medication is necessary, it must be targeted and non-addictive. Topical treatments. These should be the first line of defense for localized pain, such as knee or joint issues. Lidocaine patches can address localized pain without systemic side effects, meaning they carry almost no risk of confusion, falls, or systemic side effects. Low-dose antidepressants. Certain low-dose, non-opioid medications can modulate pain pathways. Specifically, duloxetine and certain tricyclic antidepressants can modulate pain pathways when other approaches are insufficient, providing a genuine therapeutic effect without the addictive or safety risks of opioids. Acupuncture. This ancient technique has moderate evidence supporting its use for several chronic pain conditions, offering another non-drug pathway to relief. The single most important takeaway from this entire discussion is this. For an older adult currently taking opioids, the path is always to work with a pain specialist to develop a comprehensive tapering plan while implementing these alternatives. Every medication on this list has legitimate uses. None should be dismissed entirely. But informed decision-making requires understanding the full picture, especially as metabolism slows and the body's ability to clear drugs becomes less efficient. Older adults and their families deserve to know that these effective, safer alternatives exist. They deserve to participate in decisions about their care with complete information about risks and benefits. We have covered the anticholinergic deception, the dementia and fall connection, the bone and gut sabotage, the bladder drug brain threat, and the pain paradox. The path forward involves asking questions, exploring alternatives, and advocating thoughtfully for the health of those we love. Share this information with anyone who has a loved one over 65. The conversation might feel uncomfortable and the changes might take effort, but protecting the minds and bodies of our elders is worth every single bit of that effort. Always talk to your healthcare provider before making any changes to your medications. Let the evidence sink in and understand the profound control you now have. The physiological changes of aging, the slower metabolism, the more permeable blood-brain barrier, transform acceptable risks into concerning ones. But knowledge gives you the power to transform that risk into protection. You are not a passive recipient of care. You are an active advocate. By choosing the proven, safer alternatives, CBTI for sleep, lifestyle changes for reflux, non-anticholinergics for the bladder, and multimodal therapy for pain, you are not just stopping a dangerous pill. You are investing in the precious quality of your loved one's remaining years, their independence, their clarity, and their vitality. Always talk to your healthcare provider before making any changes to your medications. Stay safe, and thanks for watching.